Welcome back. Welcome back. And another great week, another great episode of Mind, Your Body, and Soul. I am Joseph Ward. My co-host, Matthias Sweet, he's out in the street service in the community right now. He's going to pop in soon. So shout out to you, Matthias, and keep doing the good work that you're doing. But welcome back to another episode of Mind, Your Body, and Soul, the healthiest podcast that you have ever encountered. And remember, Mind, Your Body, and Soul is an educational podcast that focuses on all things health related to help our listeners learn more about various health topics and information they may not have access to. We seek to inform, empower, uplift, and mobilize our listeners to become the healthiest versions of themselves. Remember, Mind, Your Body, and Soul is available Wednesdays on our website at www.nmcpodcast.com, as well as this lovely YouTube channel. Make sure you comment, subscribe, like, share, all those wonderful things, because there's an algorithm, and the more you comment, like, subscribe, and share, the more people can get this information, because this is vital information to help our communities become healthier. As you know, we're also available on many podcast platforms: Anchor, Breaker, Radio Public, Pocket Cast, Spotify, Google Podcasts, and once again, YouTube. So make sure you support us and tell a friend about us, and just keep sharing this information, because we're going to keep giving you our great podcast. So today we got another great interview. I want to first give great thanks to Tallahassee Memorial Healthcare for the partnership we've been able to forge over the last couple of months, being able to interview some incredible doctors who are doing incredible work here in Tallahassee, and not just in Tallahassee, and outside of Tallahassee as well. So thank you to Tallahassee Memorial Healthcare. And today is no exception. We have another great doctor who's going to come in and give us some information. And we're learning about breast cancer today. And our guest is Dr. Shelby Blank, who is, and I have so many questions, but she's a board certified general surgeon at Tallahassee Memorial Healthcare and the medical director at TMH's Walker Breast Program. So we're going to learn about that. Dr. Blank leads the program's breast clinic, providing an unparalleled level of care and more efficient treatment process for patients being diagnosed with and treated for breast cancer. Dr. Blank earned her graduate degree in 1994 and her medical degree in 2001 before going on to complete an internship and residency in surgery, all at the University of South Florida. Dr. Blank is board certified by the American Board of Surgery and has over 20 years of experience as a general surgeon. Her passion is providing the most comprehensive care for women's breast health to our community, which was one of the driving factors in establishing the newest multidisciplinary breast clinic at Tallahassee Memorial Healthcare. And without further ado, Dr. Shelby Blank. Welcome, welcome, welcome.
Thank you. Thank you for having me. We appreciate all that you do and getting the word out to everyone in the community. So thank you.
Oh, no problem. The pleasure is all ours, because we get a chance to really utilize our platform to get definitive information to our community from people who are not only the professionals, but are also part of our community. So thank you for all that you do and the work and the care that you bring to your patients at Tallahassee Memorial Healthcare. So we want to go ahead and make sure we learn more about you and learn more about breast cancer, because it's something that is still pervasive in our communities, and we're wanting to make sure every year we get better and better at fighting breast cancer, bringing more awareness. So I gave a little bit about you in my introduction, but what we didn't cover, could you tell us some things that we don't know about you, but also why healthcare? Why become a doctor? What inspired you to take these paths?
Gosh, I don't know. Like many people, I think, who end up where I am, it's something that kind of was a lifelong interest. And I think it's, to me, the appeal is, number one, you're kind of combining science with humanities, because obviously you're taking care of people sort of in the most basic way, but it also is always a challenge and allows you kind of to explore the more science-oriented part of things. The other thing is, and this sounds kind of simplistic, but the instant gratification of someone has a problem and you have the tools to fix it. And there's, that's kind of really that's why I do what I do, and kind of that immediate improvement and the immediacy of what we do. So those are probably things that I find appealing.
Okay. And was, as like a high schooler, elementary schooler, was becoming a doctor something that was an interest of yours, or did that interest develop over time after going to college or being inspired along the way?
No, it really was sort of all along the path, was kind of my ultimate goal. I looked at some other things. I did some research, and really kind of always kind of circle back around to actually taking care of patients. So I would say it was sort of always on the radar.
Good. Somebody who always wanted to take care of people. That's great. That's great, because nowadays it seems different, but thank you for people who still think like that.
Absolutely.
So, okay, becoming a medical doctor and becoming a surgeon.
Mm-hmm.
Could you give us some of the similarities and differences in the mindset that it takes to be a medical doctor versus a surgeon? And because I know there's overlapping, but there's also the differences as well. So you kind of give us the differences in the mindset or the approach that you have to bring to it.
Absolutely. I think, obviously everyone kind of has a basic mindset when they go to medical school. But I think most people realize once they're kind of going down that trajectory that you're either sort of a hands-on person, i.e. a proceduralist. And so that includes kind of all the different surgical disciplines, as well as now sort of many interventional type practices, versus kind of more of the, and they would call it the more cerebral sort of practice, but I think it's all pretty cerebral. But the idea of doing procedures versus doing whether it's primary care versus a subspecialist, but you're doing more of medical management. So I think that people, I think, very early realize, hey, I'm good with my hands. I like the hands-on, and it goes back for me to that immediate gratification. To me, while it's very important to manage medications and see that long-term result, I really liked the more immediate. Someone comes in with a problem, you have the tools to fix it, and you fix it. Right. And that's so I think that's sort of the broad strokes about kind of choosing whether you go down a surgical path or not.
Okay. And so what are the requirements to become a surgeon versus the requirements of a doctor in the general sense that the average citizen would understand?
So everyone sort of has the same platform or basic training of 4 years, obviously an undergraduate degree and then 4 years of medical school. And that's all pretty standard. So that does give you exposure to all those different disciplines and pharmacology and biochemistry and all the things, the building blocks that you need no matter what field that you're going to go into. But it also kind of gives you a taste so that when it's time to apply for residency, you have a general sense of what you're interested in. And that's kind of what comes next. So that's sort of what separates different specialties or different fields, is what residency you choose to further your training. So you would either apply to a surgical residency program or training program versus one that would be in internal medicine. And then you can further subspecialize by doing a fellowship after that training. So when we talk about general surgery, you're covering a wide range of different surgical disciplines. Then there are separate tracks if you want to do, for instance, orthopedic surgery, urology, some of the more subspecialized. Once you finish your general surgery training, then you can further subspecialize in surgical oncology, colorectal surgery. There's a wide variety, as well as cardiothoracic, vascular surgery, those sorts of things. So, your basic track, the shortest kind of stretch is going to be about 9 years. So 4 years of medical school and then 5 years of residency, and then any subspecialty training that you do after that.
Okay. And so you, along your path, you develop an interest in surgery. And so is your specific surgery in helping to treat breast cancer, or is it more of a general type of surgeries?
More of a general. So everyone, even if you have a fellowship in breast surgery, you've completed a full general surgery residency, so you're pretty well versed in doing all sorts of surgical procedures. My kind of interest and niche in breast surgery sort of just kind of evolved over time. Part of it was because of referral patterns. I think when you're a female, patients with breast cancer feel very comfortable seeing a female. We have a great, complete sort of service of surgeons that take care of breast cancer in our community. I'm certainly not by any stretch the only one, but is kind of a niche that evolved because of my interest in referral patterns. But I also do other types of surgery in my regular practice. And the further I go along, the more I've kind of expanded my interest, and so then it sort of grows as time goes by.
Gotcha. Because I'm always fascinated because I use things to help me understand it. So as I'm listening to you talk, in my own time, I'm a historian, and so just studying all different facets of history. So I'm kind of likening that to what you were saying to help me understand it. So yeah, there's many different types of surgeries and surgical tracks that a person can take, just depending on their interest and skill sets and things like that. Gotcha. So. And I just learned this, so that's another great thing about these interviews. TMH has a Walker's Breast program.
Yes.
So could you please tell us about the program, and as the leader of that breast clinic, can you tell us what services that you provide at the clinic? Because I had no idea this existed.
Absolutely. This is you may have to stop me because this is something I'm very passionate about and very enthusiastic about. So one of the things that we realized, breast cancer is a very common diagnosis. It's a very common diagnosis nationwide, and it's very common in our community. So we really quickly realized that we wanted to make sure that we were offering kind of the best, the latest, all the cutting edge technology that anyone would expect and want when they were diagnosed. That started by getting our NAPBC accreditation, and that's essentially the arm of the American College of Surgeons that governs breast centers and sort of says, hey, this is this is where the bar is, and we want you to exceed that, and we want to keep moving that bar so that we know that we're delivering all the best care. So that started, and we've had our accreditation for a number of years now. And then that evolved into, how can we make this a better experience for the patient, give them a diagnosis and a treatment plan that's tailored just for them, and do it in the most efficient way possible so that we're delivering the same good care that has always been a hallmark of this area, but also doing it in an efficient way and in a way that the experience is as good for the patient as it can be. So that's kind of was our thought process and our jumping off point. And what that's evolved into is our interdisciplinary breast clinics, such that if you are in our community or our region and you're referred to our breast center, that you have the opportunity to come and in a single day's visit, you are seen by a surgeon, your case is reviewed by our entire team, which includes pretty much everyone who participates in breast care. So we go back to the beginning, we look at your imaging with our radiologist, we look at your pathology slides with our pathologist, all in as a single meeting. We have our medical oncologist, our radiation oncologist, our geneticist, we have plastic surgeons on standby. So anybody that you could possibly need are all right there. So that by the time you leave that visit, you have had a chance to have your case re-reviewed, all the recommendations made, to meet with all the doctors that might be involved in your care, and you leave with a cohesive plan. And that's great if you live in Tallahassee. It's essential if you live in one of our surrounding communities. Right. To have to drive an hour and a half for each of those visits is really is a heavy load to put on a patient who's dealing with a new diagnosis. So that's kind of where we started, and over the last couple of years have really kind of been able to grow that and refine it. COVID obviously has been a challenge for everyone, and so but breast cancer doesn't stop because a pandemic happens. You just have to figure out kind of how to work around it, and I think we've done a hopefully a good job of doing that. So.
Yes. And just a minute. Welcome, Matthias. Welcome.
Hello there.
You're on mute. He's getting his sound together, so we can pick back up to what you were saying. Because
hey, I'm sorry I'm late. I've been coaching.
It's okay. I'm just as excited as you, so I definitely have to follow up with that. But welcome, Matthias. Welcome. Matthias, this is Dr. Shelby Blank. Dr.
Hello
Blank,
there.
Matthias
Nice to see you.
Nice to meet you.
So-
Nice to meet you.
So to
What's
bring you,
going on?
so the man, we're having a great conversation about Dr. Blank, what she does, what she brings to the table as a doctor and a surgeon, and she's giving us information right now about TMH's Walker Breast Program and the breast clinic and the services they provide. So we're learning about that now. We're about to go into more about breast cancer, but just learning about the Walker Breast Center. And so to bring you up to speed, and I was just going to say this anyway. Okay, so the way she just explained the Walker Breast Center, so the way it computes in my mind, it is in a lot of our listeners, if you're familiar with how HIV services are given. So if a patient comes to neighborhood now and the patient is found to be HIV positive, we're basically going to throw the kitchen sink as far as services at them. And so a one-stop shop. So basically, Dr. Blank just explained to us that when the patient comes into the Walker Breast Center, the breast program, and it needs services, needs care, they have a comprehensive, full service team of services around the clock, like all the services that a patient would need. So you won't have to, like she just explained, you won't have to go back and forth. So one-stop shop where you can get all the information and all the services you need, and a comprehensive health team to help you help yourself through the process.
Oh, that's amazing.
Well, we realized that there was a long stretch of time where patients were going through all these processes, but between the time that they got to call about their abnormal mammogram, and then to get a biopsy, and then to meet with one person and then another person and have a plan. And our goal is obviously to make that timing shorter, to offer more support to the patient and kind of get them to treatment, because that's a anxiety producing stretch of time. So and I think we've really made a lot of inroads and have gotten really good feedback from patients that it's been a positive from their standpoint.
Well, good.
Right.
Good. No, I'm happy for that, because it is tiresome sometimes trying to figure out how to get it, and then once you do the mammogram screening, then you do the self-breast exam, then you do the mammogram, then you do the biopsy, trying to make sure you get the patient to all those different things, and sometimes they have to go different places to get it done, and so it's like it's frustrating. I understand.
Right. So I'm glad you said that, because you made me think. Okay, so I'm the guy that knows nothing about the mammogram. If a woman goes in for a mammogram, okay, I don't know what happened. And so I know there are a lot of other people.
You can go in for a mammogram as well. Like a lot of guys don't understand, you can get breast cancer, especially if it's predominant in your family. Some guys also need to get checked out as well. Am I right?
That's absolutely correct. So we don't, because it's not as common, we don't do routine screening. And it's also typically easier to feel an abnormality in a male because there's less surrounding breast tissue. But absolutely, men are at risk for breast cancer. Oftentimes there is a family history, and you may, if you have something abnormal, you may be sent for a mammogram. So absolutely.
Right. So exactly what goes on during the breast exam? Like, how does that happen?
Okay, so surveillance and screening for an average risk patient is kind of two-pronged, and part of that is a clinical breast exam, which is an exam by typically your primary care provider or your gynecologist, and that just examines all the regions of the breast. It looks at the skin, it looks for any discharge, it looks for any palpable lymph nodes under the arm. And I always tell patients it's very hard to know kind of what's normal lumpiness versus a suspicious mass. So I tell patients it's more about being self-aware than necessarily trying to expect yourself to be a doctor and
Right.
diagnose your own breast cancer. So the biggest thing is just if you feel something or note something that's abnormal or different for you, have it checked out. So, and that's probably kind of an evolution from the once a month, breast self-exam. Right. Routine mammograms, we recommend starting at age 40, once a year. So when you go in for a mammogram, like you said, it's this sort of mystery to people that have never had one. Essentially, it's a special X-ray, and it's an X-ray through the breast tissue. Now you may hear people complain like, oh, mammograms hurt, or it's uncomfortable, or I don't like it. Well, the reason some people say that is because we do compression of the breast tissue to get the best picture. And so that for some people, they don't really like it very much. We've come a long way with a lot of padding and new machines and ways to kind of mitigate that. So I would say that the vast majority of folks, it's not an unpleasant or uncomfortable. So I don't want people to avoid getting mammograms because they feel like it's going to hurt or be uncomfortable, because that's typically not the case. Right. And that's sort of just your kind of general surveillance.
Okay. So why is it recommended, or why are most mammograms given at the age of 40 and up?
Well, we know that the risk for breast cancer increases as our age increases. Mm-hmm. Now, does that mean that people less than 40 can't get breast cancer? No, but certainly that risk goes up. And also mammograms in women that are less than 40, because of the density of the breast tissue, is not as good of a test. So we balance everything about, that we do in medicine with what's the benefit, are we really doing good here? Are we accomplishing what we're setting out to accomplish? So we realize that in younger people, it's not as good of a study because of the density of the breast, and the risk is lower. So we feel like 40 is kind of that point where that analysis shifts, and it's a better test with a higher risk.
Gotcha. So, okay. But under 40, the routine self-breast exams is recommended.
Exactly. And if we note something, then we have a variety of imaging techniques, whether it's MRI, ultrasound, or going back to mammogram to evaluate those. And I would say the only exception to that is if you do have a family history. So, mother, sister with breast cancer, we typically recommend that your surveillance starts a little bit earlier. So 10 years prior to the age of diagnosis. So if your mom, for instance, had breast cancer diagnosed at 45, you would need to start being screened at 35. There's a lot of genetic predispositions. Honestly, those are the vast minority. So there's only probably 5, maybe 10% of folks who truly have an inherited type of breast cancer. So people have sometimes, I think, a false sense of security of, well, there's no one in my family that's ever had breast cancer. And that's actually by far the most common place that we find people with a new diagnosis. So.
Okay. So that leads us to this next question. Understanding breast cancer. What is breast cancer? How does breast cancer form? Because like you said, 5 to 10% can get it genetically. So what are things that, first, what is breast cancer? What are things that cause breast cancer? And we talked about it in men, and this may not be the best question, but I'm asking anyway. Does breast cancer only affect the areas in the breast, or can this cancer affect other parts of even the chest cavity or the body?
So breast cancer it starts in the breast. That's pretty much a universal. Now, the problem becomes more significant when those cancerous cells spread either locally, in which case they can, invade the skin, they can invade the chest wall. But more commonly and more concerning is when those cells spread initially to the lymph nodes that surround or drain the breast tissue, so normally under the arm, and then they can travel really anywhere. So breast cancer can spread or metastasize, is the word we often use, to the brain, to the bone, to the lung, really other places. And that's when it becomes more difficult to control, treat, if we want to use the word cure. but breast cancer is always going to essentially originate within the breast. Sometimes it stays in the breast, and that's the goal, is if we're going to find a breast cancer, to find it at that very early stage where it hasn't had an opportunity to spread anywhere else, to those lymph nodes or to other distant sites.
Okay, so it starts in the breast, but if gone unchecked over time, it can spread up.
Exactly.
But it would still be considered. So would that still be considered breast cancer once it spreads?
Yes.
Okay, I got you. Okay. And so exactly what is breast cancer?
So breast cancer is essentially development or overgrowth of abnormal cells. So these can either be cells from the breast duct, or what we call ductal carcinoma, or from the lobules of the breast, and that just differentiates, what was the cell of origin. So those cells we all kind of have, repair mechanisms that our body kind of recognizes cells that are abnormal and tries to control or kill them. But sometimes, and we don't always know exactly why this happens, those repair mechanisms don't exactly work right. And so it allows these abnormal cells over time to proliferate, and they start growing faster. And initially they will just be a few cells, but over time they will actually develop and invade the local architecture of the breast and form a tumor or an actual mass. Some tumors will stay local to the breast but just get larger. And again, some, even at a very small size, can start to spread. That's clearly a more concerning, type, the kind that spread early, because those are more difficult to treat. Typically, our treatment is going to be, if we find this at an early stage, to surgically remove it, so to cut the cancer out. But we also often will have to pull in other modalities of treatment, which typically are radiation in some cases and chemotherapy in some cases. Not every patient with breast cancer will need all three of those, but usually a combination.
Gotcha. Okay, well, that goes into the next question about the treatments, because I'm familiar with seeing women after they have mastectomies,
Mm-hmm.
or seeing commercials on TV where, and it's not detailed, but you'll see the woman and they show her with her after her hair has fallen out, and she's usually in the hospital gown, and they're talking about it. So there's a image that is put out there that kind of, I know, it's stuck in my head about what a woman would look like going through breast cancer and the various things. But you just hit on it. So surgeries, radiation, chemotherapy, those things are used to treat breast cancer. Are there any other ways of treating breast cancer outside of those three?
So those are kind of the primary things we think of. And within that chemotherapy side of things, there is, we kind of break it down into what we call cytotoxic chemotherapy, which is kind of what you're talking about. That's sort of the hardcore chemotherapy. They usually get it through an IV. It makes your hair fall out in some cases. It's a little bit of a harsher treatment, but for more aggressive cancers or later stage disease, we may need that. There's also kind of a new class of treatment that we call endocrine therapy or chemo prevention. But essentially, these are medications that treat cancers that are sensitive to certain substances. So most of the time, estrogen or progesterone. So we know that these sort of anti-estrogen medications can treat cancers and also lower the risk of developing another cancer down the road. So people may have heard of medications like tamoxifen or letrozole, Remedex. They're different classes, but they all sort of achieve a similar goal.
Gotcha. Okay, so cytotoxins are...
So cytotoxic, right, is more like what most people think of chemo, as chemotherapy.
But that is the dominant image that we mostly see when it comes to treatment, but it doesn't have to come to that.
Correct. So it is, and it's a, and probably because it's it's a powerful image. Mm-hmm. But I would say that the vast majority of patients that I treat don't necessarily need a mastectomy and don't necessarily need that more aggressive chemotherapy. Right. The real key is one, the type of cancer that you have, and two, the stage of diagnosis. So that's one of the reasons that screening and surveillance is so important, is we are finding these at an early stage, the likelihood of you needing that more aggressive treatment is certainly much lower. We know a whole lot more about the types of breast cancer that are out there. It used to be, it was sort of, one diagnosis, one treatment. So everybody kind of got everything. And over the last probably decade to 2 decades, we've really realized that that breast cancer is not one single disease, and there's a lot of different types, and the way we treat that has certainly evolved. And some people we treat more aggressively, and some people less aggressively based on the type of cancer that they have.
Right. Okay. And one of the reasons I am asking is I have a neighbor who she's going through breast cancer now, and she's doing good, but I know she has a lot of questions. I have a lot of questions, but I guess one of the things that we normally think about, and I hate to go here, but just trying to be as informational as possible, is people think about death and mortality and all those things when it comes to cancer, because that, for a lot of people, the idea is the C word, it's the big C word, and we can't talk about it. But can you tell us about how just the technology and information and the skill sets of doctors over time has helped the mortality rate of people with breast cancer?
Right. Absolutely. So when we talk about breast cancer, obviously what the first thing that patients will often ask is, am I going to die from this? Because that's the question that nobody wants to ask, but everybody, that's what you're thinking. And so really everything that we're doing, whether it's surgery, radiation, chemotherapy, is designed with the single goal of improving survival. In other words, preventing you from dying from your breast cancer. And I would say that earlier diagnoses, we believe, will equate to improved survival. But again, a lot of that goes back to what type of cancer that you have. And a lot of the research, you'll hear people use the term targeted therapy. And that's a lot of what we're doing in breast cancer, is kind of figuring out exactly, what are targets that we can treat specifically, rather than just kind of carpet bombing, if you will, the whole cancer. I think that certainly the vast majority of patients that we diagnose have a very favorable prognosis, that they will not die from their breast cancer. But there is a small subset who are either diagnosed at a later stage or simply have a very aggressive type of cancer, and that's the bar that it's been difficult to move in terms of survival. But like I said, monoclonal antibody type therapy, targeted therapy, the new oral medications, figuring out, gosh, this is a person that we may need to treat with chemotherapy first before surgery. Not so many years ago, everyone with breast cancer got a very aggressive operation where we took chest wall muscle and all the lymph nodes. And that was a very morbid, if you will, operation. In other words, it had a lot of side effects. And we don't really do that anymore, because we realize we can give better, or at least as good of survival with much less side effects, by using these other options, such as medication, radiation, and et cetera. So the vast majority of folks that are diagnosed really won't end up with a mastectomy. They will often get a lumpectomy, or what we call breast conserving therapy, coupled with external beam radiation, and they have great results. So breast cancer doesn't automatically mean chemotherapy and losing your hair and being sick. It doesn't automatically mean you're going to die from your breast cancer. In fact, that's the vast minority of patients, and it doesn't necessarily always mean a mastectomy. Okay. So for patients that do need a mastectomy, we also have great reconstructive options. So we have a great team of plastic surgeons that can come in and in most patients offer really good reconstructive options.
That's good. That's good. I got a question. I have a patient now who had a double mastectomy. Do y'all have anything that, if they don't want the breast implants, do y'all have anything else that makes them kind of, give the image of, like, I guess, a plate or like a bra that's already made up like that? And how do they get access to those type of things?
Absolutely. So there are different types of reconstruction. So surgically, most people think of, in our community, kind of most people go with implant-based reconstruction. There is also flap-based reconstruction, which is using a muscle flap or another kind of part of your body to rotate and create a new breast contour. But for people who either aren't a good candidate for that or don't want that, yes, there are great options for special bras, special prosthetics that, when you're enclosed, recreate kind of just what you looked like before your surgery.
Right.
There are also some people like those, some people don't. There are also, even outside of kind of the more, medically mass-produced prosthetics. There's, and this is a crazy, funny name, but it is what it is. They're called knitted knockers. And somebody came up with the idea because they had been through breast cancer and realized that the prosthetics were often heavy and hot, and they didn't really like them. And so they kind of created this knitted version that's a breast prosthetic that's very light, it's washable, and you can throw it in the, it's inexpensive, and you can throw it in the washing machine. So people are really ingenious when it comes to kind of figuring it out. So yes, just because you've had a mastectomy and maybe didn't choose to or weren't a great candidate for surgical reconstruction, there's a whole lot of different ways to maintain and kind of have your external image and body contour to be much as it was before surgery.
Right. Okay. So I have one more question on the treatments, and I'm asking this because we're in this age of social media where we just learned that if it's on a meme, then it's true, because memes are they're true, right? But we're also in the age where people are looking for alternative ways or naturopathic ways to treat all different types of things. And I hear a lot of people using different natural remedies or natural ways to treat cancers. One of the most popular I've heard about is cannabis oils and all those different things. So what recommendations would you give to someone who wants to take a more naturopathic route to treating their cancer?
So I think that I think there are a lot of things about cancer, breast cancer, and other types of cancers that we don't 100% understand. And I think that anyone in the medical community would tell you that we're learning stuff. And in breast cancer, it's rapidly evolving. What we may think or know 6 months to a year from now may be very different than what we're knowing now. Now, again, I don't think that's a radical, gosh, what we were doing then was wrong. It's just we're learning more, and that bar keeps moving. I think that I would not have any concern about adding, as long as they weren't harmful, adding things that make you feel better as you're going through your treatment, or are based on evidence-based studies that we have. So we know that certain natural things are natural estrogen blockers or natural estrogens that might not be great for you. So, but I would also tell people to not be short-sighted and close the door to traditional therapies, because you can bring both of those things to the table, and benefit from both. So it doesn't have to be an either-or decision.
Okay, thank you for that.
I got another question. So if the woman wanted to she had the double mastectomy, but then decided not to, do they automatically go into the breast plant stage, or do they have to wait until the cancer's in remission? What happens? And then if they don't decide to get it right then, is that a hard process for them? Do they have to use the spacers to stretch the skin? Is it more painful?
Yeah, no, I mean, the folks that are good candidates for immediate reconstruction are people with certainly earlier cancers. Obviously, if you're going to need radiation chemotherapy, we don't want to put you through more surgery that might delay your other treatments. Now, that doesn't mean that just because you're going to need those, you're not a candidate for immediate reconstruction. We're just a little more careful.
Right.
People who are smokers, people who are poorly controlled diabetics, people who are very, very heavy, those are all risk factors for further surgery. So those are people that may be more recommended for delayed reconstruction. Or people that just say, gosh, I just want to get through the cancer part and then I'll worry about the reconstruction later. You're not burning any bridges. We can certainly do delayed reconstruction. It's just, once you've healed and recovered from your breast cancer, you're not, precluded from having that at all. And I don't think it's really any harder or more difficult. You're bundling it into one operation and one recovery, from a timing standpoint is a little bit easier. But it doesn't mean that having it, a year or 2 years down the road is going to be much more difficult. It's just not.
Okay.
Gotcha. So we talked a bit earlier about men and breast cancer, and I kind of want to get back to that because we have no concern. Most of us have no concern at all about breast cancer. And as you stated earlier, men can get breast cancer. It's less likely chance that men can get breast cancer. So the first question within that is, what increases a man's risk of developing breast cancer?
So probably by and large, the most, the most increased risk factor is going to be the strong family history, and if his, if there is a history of BRCA positivity, so carrying the breast cancer gene. But other than that, there are, certain types of history to exposure, certain types of radiation earlier in life, those sorts of things. Most of the time, that's not going to be a hidden risk factor. If you've had that, you're going to know that. By and large, the folks that I've seen do not really have a strong, identifiable risk factor. It's kind of one of those just, sometimes things just happen. So I do caution, all men, and particularly as you are, older or later in life, if you notice something that's abnormal, male breast enlargement is not super uncommon, and that doesn't necessarily mean cancer or make you at more risk for cancer, but a mass or something that's happening on one side that's not happening on the other, something you feel on one side and not the other, that certainly raises more of a red flag.
Gotcha. So if a man does discover he has breast cancer, here in Tallahassee and the surrounding areas, what treatments or services are available for that man?
We treat them much of the recommendations, because it's, so much of the research was done in women, but we don't find that it's terribly different in our male population. Generally speaking, most people are going to have a mastectomy because removing all that breast tissue is not, is not terribly different for a man, and they're saving themselves radiation. That doesn't mean it's, it's the only path, but it's typically what we'll recommend and change. There's not a lot. We have to, when we take a cancer out, we have to have good margins of tissue. And so there's really oftentimes not enough tissue there to really warrant not doing just a complete mastectomy. But by and large, male breast cancers are treated, quite similarly to females. Generally speaking, like I said, the main identifiable risk factors are going to be that kind of family history.
Gotcha.
So, since we talked about the different processes and things, can you walk us through what really goes on during surgery, trying to remove the cancerous tissue?
Sure. So it's a little bit different depending on if we're going to do a lumpectomy versus a mastectomy. So a lumpectomy, we're really kind of focused on that specific area where we know the cancer exists. When a patient has a biopsy, generally we'll leave a little marking clip, which is just a tiny, tiny little titanium marker at the spot where the biopsy is done. That allows us to kind of have a roadmap when we go back to take the cancer out, if that biopsy turns out to be positive. If the biopsy is negative, that marker can stay there forever. And we know down the road when we see it on mammogram that's an area that's already been biopsied and is not a problem. So for a lumpectomy, we come in and we localize that area, the spot that we want to take out, usually by doing more imaging on the day of surgery and putting a little guide wire or a special marker that goes to that spot. Then we take the patient to the operating room, make an incision. We try to make it as hidden as we can, and we take out the tumor as well as a surround of normal tissue. We do some imaging once we take that tissue out and make sure that that we're, to the best of our ability, we've kind of gotten the area we were concerned about. At the same time, we also check the lymph nodes. We do something called a sentinel lymph node biopsy. As we talked about earlier, one of the ways that we stage breast cancer and give a good idea of prognosis is if that cancer is just contained to the breast versus cells have moved or spread to the lymph nodes. So that's what the sentinel lymph node biopsy is designed to tell us, is has there been any spread of that cancer to the lymph nodes? And we put in sort of a special tracer material that gets taken up by those lymphatic channels and carried to those lymph nodes. So we kind of know which are the first lymph nodes that a cancer cell would go to, and we take those out and test them. We do that same process for a mastectomy. If a mastectomy is the plan, then instead of doing a localization, we know we're going to take out all the identifiable breast tissue. So we don't really have to localize that tumor because we generally know it's going to come out.
Okay.
If we're doing a procedure with the plastic surgeon, we may do kind of a different shaped incision, but a standard mastectomy without reconstruction, you're going to have kind of an elliptical incision, which makes essentially kind of a straight line incision across the chest wall once that's all closed. A lot of times patients will come in and say, well, what's going to cover that area? Well, your own skin will cover that area. So we leave skin. The only exception to that would be if there was, cancer involving the skin, which is kind of unusual, but does happen. But we work around that in those unusual situations. But generally speaking, the cancer is not going to extend to the skin surface, and we're able to leave that as your coverage, whether we're doing reconstruction or just a standard mastectomy.
But as you explained, though, the advancements in the surgeries and the instruments used for surgeries have left less revealing scars and incisions on the person, rather than a person coming out feeling like they'll just have all type of telling scars over their body. It's not what it used to be back in the days.
That's exactly right. That's exactly right. So I think, and there's just a lot more options, and every patient's different in kind of what, and sometimes it's hard because patients will have to make a decision because they'll have two really good options for treatment. And it kind of comes down to what their preference is, whether they want a lumpectomy versus a mastectomy. So they all have the kind of pros and cons, but we're obviously going to guide you on the best cancer options. But sometimes that still leaves some of that decision making with the patient, which is a good thing.
Right. But and also for our audience, also then we highly encourage you to do as much research as possible to learn as much. But remember, Dr. Google is not the end all be all. It's just to help get you a base, a foundation of information. It's not to say that you take this and run it as the expert, but you want to have some kind of knowledge of what's going on, and then ask questions from there.
Absolutely. There's a lot of great information. You just want to make sure that you're getting it from, legitimate scientific or medical websites. I always discourage patients from going to sort of, this is my experience, because everybody's experience, everybody's breast cancer is a little bit different. And so trying to base what's going to happen to you on what's happened to someone else, it's good to have support from people who've been through it, but your path is not going to be exactly the same as their path. And I also tell people that a lot of the stories that you might run across on the internet are people who've had, a bad experience in one way or another, because the people with good experiences are living their life and playing with their grandchildren and traveling on vacation and doing all those things. And while they do, I think we have a very active, breast cancer community, both locally and nationwide, realize that's, that one person's experience is not going to necessarily mirror yours. So to try to not be fearful when you read those sorts of experiences.
But also, seeing them continuously on commercials over, especially now, because I can I can see the commercial while I'm watching TV. I can see that same commercial while I'm on social media on my computer. I can see that same commercial while I'm on something on my phone. And so they've advertising has tapped into every piece of technology that we have, but it's still going back to the actual information. Just because you see this message so frequently doesn't mean this is the norm.
Exactly.
So, all right, and so we're winding down, but you touched on it as well, because we talked about the cosmetic surgeries and things like that. So, of course, we are in a time where cosmetic surgery is very, very, very popular, and I want to make sure people have an understanding of the difference between cosmetic surgery for health reasons and cosmetic surgery for beauty reasons, because there's a difference. And so can you kind of touch on it from the standpoint, and I know you're not necessarily, you haven't told us that you're a plastic surgery doctor, but plastic surgery doctors, can you help us explain, aren't just for beauty, like personal beauty cosmetic reasons, they're for health reasons as well.
Exactly. I think when we think of a plastic surgeon, we typically kind of think of, breast augmentation or facelifts or tummy tucks,
right.
or, and certainly the cosmetic side of things is an important part and a chunk of what they do. But a huge part of their practice is also reconstructive surgery after cancer, and other, trauma, accidents, those sorts of things. So we do work really, really closely with our local plastic surgeons, and they're great in terms of giving patients good cosmetic outcomes after cancer surgery. So as we talked about, reconstruction often can be done, at least the first step of reconstruction can be done at the same time as the original cancer surgery. And that reconstruction can come in a lot of different forms. Certainly, reconstruction after breast cancer is very different than breast augmentation. Now, they may both use an implant, but the similarities kind of in there. We also can use patients' own tissue in some cases instead of an implant.
Right.
There's also options for what we call oncoplastic surgery, which is kind of one of the newer formats, and essentially that's combining a lumpectomy with a breast lift and reduction. So the idea is we're taking this tumor out, and so patients that may have always desired breast reduction surgery, that allows us to get very wide margins and also give patients a good cosmetic outcome because we're kind of doing a lift and a reduction at the same time. So, and all of these, one of the most common things that I get asked is, does insurance pay for these, for reconstruction after cancer? And the answer is absolutely yes. So I don't want anyone to kind of not seek care or not explore all of their options because they're concerned about, about the financial implications, because this is part of your whole cancer treatment.
And so you mentioned breast reduction. So question popped in my mind. If a woman gets a breast reduction, will that decrease her chances of developing breast cancer?
I would say not in any probably substantial way, because she's still going to have a fair bit of breast tissue left. Can you say, well, gosh, there's less tissue there, so there's less chance? So yes, in some way, but we haven't found it to be, and it's hard to know too, because, if you don't know who would have formed, a breast cancer, in that tissue that was removed. We know that we do test the tissue that gets removed in a breast reduction, and once in a while we do find kind of a hidden cancer or pre-cancer that no one really was aware of. So we do know that exists, and certainly removing some of that breast tissue, but I don't think anyone's ever shown that it's a significant risk reducer.
Right. And further with that, breast reductions are healthy or are conducted rather for women to help relieve some of the burden on their back, or how does that work?
Right. So typically it's going to be for people who have, chronic back pain, shoulder pain, kind of physical ramifications from their large breast size. And those are the people that kind of, while there is a cosmetic, there may be cosmetic, accommodations and considerations. The real reason that people do it is for that physical reason.
Right. Okay. I got you. All right. So, down to our final question. I want to thank you. I've learned a lot. I know we threw 100 questions at you because our minds were going, but we definitely appreciate it. But what should women know about their breast and their overall bodies to help reduce chances of developing breast cancer or any type of cancer?
Like I said before, I think one of the biggest thing is not ignoring something that's different.
Mm-hmm.
So kind of just be aware. That doesn't mean, gosh, every week you have to do this, aggressive exam. It means be kind of at least cognizant enough of what's going on with your body that you notice when something is abnormal. I think in people that have, we're realizing that as your risk goes up, whether it's because of family history, age, what have you, that probably not taking a lot of extra estrogen is probably a good idea. If you have a strong family history, it's probably a good idea to have that conversation with your physician, maybe get into one of our high-risk kind of screening programs so that we know that if you need genetic testing, we can do that. If you need high-risk screening, which is kind of a different box of folks that you're in that. And there's also medications, some of the same medications that are, pill therapy that we treat breast cancer can also be a risk reducer for people who have a very high risk for breast cancer. So it's not always now just, well, gosh, I keep my fingers crossed and hope this doesn't happen to me. There are actually some overt things that we can do to reduce that risk.
Gotcha. And that's why we do these podcasts. That's why this podcast exists, these interviews, for information like that, because it's different from, like I say, the normal narratives that we always get on repeat all day. And we understand from that standpoint, not necessarily from TMH or the real medical providers, but from a TV standpoint or a social media standpoint, people are trying to convince others to do this and do that. But real information is what empowers us to keep ourselves safe. And real information is what empowers us to inspire others and help others to be safe and create safe spaces. And so that's why we do this. And thank you, Dr. Blank, once again, because this was incredible. We definitely learned a lot, got a chance to ask all of our questions. So before we let you go, though, if somebody sees this interview and say, hey, she gave great information, could be CNBC, TED Talk, Fox, whoever, they want to get in contact with you, what's the best way someone can get in contact with you for more information or to have you on their platform?
So probably the easiest way is to get online. And my office number and contact information and emails there, and also that of our breast clinic. So we have Amy Anderson, who's our breast cancer navigator, who is a great resource also. But probably going through the easiest way is just the TMH website, and that'll give you all the numbers and emails for everyone kind of involved in the program.
And that's tmh.org. So make sure you check out the website, and that way you can learn more about Dr. Blank. You be able to get in touch with Dr. Blank, and all of the information and experience and just the enthusiasm and passion that she brings to the job. We greatly appreciate you for what you're doing for our Tallahassee community, and we wish you so much success. And also, if there's any way we can help you here at Neighborhood Medical Center, you let us know, and we'll gladly step up to the plate.
I appreciate it. I think just getting the word out about screening mammograms, and obviously, if you have something abnormal, give us a call. We'll scoot you in and get it taken care of. If you don't have a primary doctor or you don't have kind of a network there, don't let that kind of impede you from getting that care. We know that there are certain the Jewish population, Hispanic population, and Black African American population tend to have be diagnosed later, have more risk, and so those are really communities that absolutely need that screening piece of things. So if there's any way we can help you, please let us know. And I really appreciate what you guys are doing, and thanks for having me on.
No problem. Thank you for being on with us, and we definitely talk to you soon.
All right.
And remember, everybody, this is Mind Your Body and Soul, the healthiest podcast ever. I'm Joseph Ward. Matthias had to pop in and out because he had to do some testing and stuff all up people's noses. But hey, they're safer. So remember, Mind Your Body and Soul is an educational podcast that focuses on all things health related to help our listeners become or learn more about the various health topics and information that they may not have access to. We seek to inform, empower, uplift, and mobilize our listeners to become the healthiest versions of themselves. Remember, every Wednesday, www.nmcpodcast.com. That is our home. Check us out. Also visit our parent website at www.neighborhoodmedicalcenter.org. We're also available on Anchor, Breaker, Radio Public, Pocket Cast, Spotify, Google Podcast, and YouTube. Subscribe, share, comment, like, so many people can see this. With that being said, we are out of here. We'll see you guys next week, and stay healthy, my friends.
Thank you.
Thank you.